Hello, I'm Bob Marion. I'm a medical geneticist at Montefiore Medical Center and the Albert Einstein College of Medicine in the Bronx. Thank you for inviting me to participate in this important conference. My role in the panel is to talk about how molecular panels affect the survivors of decedents who die suddenly. And I'm going to do this by talking about some of the families that we've seen at the Montefiore Einstein Cardiogenetics Clinic in the Bronx. The objectives of today's talk are first to describe how results of molecular testing of decedents' DNA can impact the lives of their survivors. And again, I'll do this through presentation of a couple of families that we've worked with in the Bronx to describe how our multidisciplinary cardiogenetics clinic actually works, and also to describe the interaction that we've developed between our clinic and the New York City Office of Chief Medical Examiner's Medical Genetics Lab, and Dr. Tang and other personnel in the lab. So first, though, I'm not sure the level of knowledge of members of the audience. So I'm going to just start off by giving you some background on precision medicine. So precision medicine is defined as an approach to patient care that uses information about the patient's genetic background and the environment in which their genes are being expressed to develop a personalized plan of treatment and prevention. So conventional medicine has always waited for patients to develop symptoms and signs of disease and then has provided treatment. So for instance, people who have asthma are fine most of the time, but then develop wheezing and shortness of breath and other symptoms. And at that point, what physicians do is they kind of throw medication at the patient. They'll give them bronchodilator. And if that works, fine, and they'll move on. If that doesn't work, they'll give them a steroid. And if that works, fine. And if it doesn't work, they'll move on to something else. So basically, what we do is throw medication at symptoms and signs without really having an understanding of what the underlying cause of the disease, of the symptoms and signs that that person's having are. What happens in personalized precision medicine is that we shift this paradigm because we understand, because of their genetic background, that they have a predisposition to develop symptoms and signs. And we understand, or we should be able to understand at some point, which symptoms and signs are going to respond to which medications because of pharmacogenomics. And so then we can take steps to prevent these symptoms and signs from occurring. So we're actually being proactive rather than waiting for symptoms and signs to develop. And really, our cardiogenetics clinic is example of precision medicine in action. Our clinic was founded in 2006 by Tom McDonald, who's an adult cardiologist, Christine Walsh, who's a pediatric cardiologist, and myself. We came together because we understood that the new advances in molecular genetic medicine had given us the opportunity to work together to provide something really special, we thought, for families with inherited disorders of the cardiovascular system. And so in order to do this, we assembled a team. We have a genetic counselor who's the coordinator of the clinic. We have, as I said, an adult and a pediatric cardiologist who are expert in rhythm disorders, electrophysiologists, a medical geneticist, myself, and a nurse practitioner, all working together in the same place at the same time, seeing multiple members of families usually. We also have assembled multiple team members, social work, psychologists who are expert in bereavement counseling. We have an ethicist who we call on if we have questions of ethics, and others, an attorney, basic scientists, and others. We also have an assortment of trainees from pediatric and adult medicine and fellows in cardiology and medical genetics. So we sometimes have 10, 12 people in a room seeing patients simultaneously. It sounds like utter chaos, but I think it works really well because each of us brings something different to the delivery of care to these individuals. And this is an early picture of our clinic team going around the room. I'm on the left. Christine Walsh is next to me. One of our cardiology fellows is next to Christine. Another medical geneticist is next to him. Tom McDonald is at the top on the right, and Esma Peljevic is a nurse practitioner and another genetics fellow next to Esma. So this is an early picture of our team. We also made up this brochure to give to providers and families so that they have an understanding of what we're doing. And also early on, we developed an important relationship with the Office of Chief Medical Examiner in the city of New York. And I'll tell you how that relationship actually started in a minute. But as some background, as you probably already heard, the molecular genetics lab at the OCME performs genetic panel testing on decedents in whom the cause of sudden unexpected death, especially in younger individuals, was not apparent at the time of autopsy, or postmortem findings suggested a possible genetic diagnosis. And that included hypertrophic or dilated cardiomyopathy, thoracic aortic aneurysm and dissection, and other causes. It's an interesting story how the molecular genetics lab started, and I think I cover some of that in the essay that you may have been given called The Kid Had to Pee, which describes one of the patient interactions that I'm going to talk about today. In 2007, soon after our clinic started, Tom McDonald reached out to Dr. Tang, the director of the lab, to discuss a family, again, which I'll talk about in a minute. And from that time, we developed this relationship. The molecular genetics lab can't offer testing to the living. They are only offering testing to decedents. And so if a genetic abnormality is identified, it's important for the family who may be at risk for the same fate as the decedent. It's important for the family to be referred to someone for testing and for genetic counseling. And so we started that relationship in 2007. And since that time, the lab has begun referring families to us for evaluation. In an important step, about 10 years later, in 2016, the lab hired a certified genetic counselor, Nori Williams, to interact with the families of the decedents in whom genetic testing was being done. Nori became the first genetic counselor to work for a medical examiner, I think, in the world. And although she's left, she was succeeded by Sarah Saxton, who you'll hear from in just a little while. So, in fact, Nori and Sarah have come to our clinic when we've seen families that they've referred to us. So our relationship is so close that we actually can see patients together. So let me tell you about that first case that brought Tom McDonald and Dr. Tang together. And this was a woman named Miss V. Miss V was a 24-year-old who had been in good health. One morning, her son, a 6-year-old son, found her dead on the bathroom floor. His father began CPR. EMS was called and arrived within 10 minutes, and CPR was continued. And Miss V was transported to the ED. Resuscitation was begun or was continued but failed, and she was declared in the ED. It was clear that she probably had been dead for a few hours by then. An autopsy performed by the Office of Chief Medical Examiner revealed the presence of alcohol and cocaine in body fluids, and her death was signed out as drug-related. But she had a significant past history. Miss V had been seen about 1 month before her death after an episode of syncope, and had a workup in the emergency room. She had, among the things that were done for her, was an EKG, which was happened to be read by Dr. McDonald, and it revealed that she had a prolonged QT interval. She had been referred to cardiology for possible long QT syndrome at that point, and an evaluation had been done, which revealed a positive family history, family members who had died suddenly of unknown causes. She had a normal physical exam. She had an EKG, which confirmed that she had a prolonged QT interval, an echocardiogram, which was normal. A Holter monitor was done, which showed only rare PVCs, and a stress test, which also showed prolonged QT interval, which got worse with exercise. So based on the history and the EP studies, she was referred to our clinic for genetic evaluation, for genetic counseling, and possible genetic testing. The appointment was made at the time of her cardiology visit for a couple of weeks later, but in the interval between the cardiology visit and her appointment with our clinic, she passed away. So because of this past history, Dr. McDonald reached out to Dr. Tang, and Dr. Tang performed the genetic panel for sudden death that she had devised earlier. And the panel in Miss V revealed that she was heterozygous for a pathogenic variant in a gene called KCNQ1, and KCNQ1 encodes a protein that forms the potassium channels, and pathogenic variants in this gene are associated with long QT syndrome type 1. So let me give you a little bit of background about the cardiac channelopathies, not going into too much detail, but these are abnormalities in protein that form or regulate cardiac ions and lead to malfunction of those channels. So basically, these are channels in the cell membrane of cardiac cells, which allow the inflow and outflow of different ions, which the movement of the ions in and out of the cell create an action potential, which allow the passage of the cardiac impulse from one cell to the next. And that's really the basis of how the heart beats, that movement of the impulse down the line. The types of cardiac channelopathies that are seen include long QT syndrome, which we're going to talk more about in a minute, short QT syndrome, something called Brugada syndrome, and catecholaminergic polymorphic ventricular tachycardia, which for obvious reasons is called CPVT. So pathogenic variants in specific genes can lead to loss of function mutations or loss of function of the cardiac channels, and that's the basis of Brugada syndrome, or gain of function in the cardiac channels, and that's the basis of the long QT syndromes. So long QT syndromes are caused by pathogenic variants in 15 separate genes. And there are probably many more, but these are the ones that have been identified so far. However, only 3 of these are common and account for more than half of the cases of long QT syndrome. Long QT syndrome is diagnosed on the basis of a clinical or the electrophysiologic finding of a prolonged QT interval. And the 3 major types of long QT syndrome are long QT syndrome type 1, which is due to a pathogenic variant in the potassium channel gene called KCNQ1, long QT syndrome type 2, which is usually caused by a variant in a gene called KCNH2, another potassium channel gene. You can tell what type of channel you're dealing with by the first letter of the gene. So if it starts with a K, you know it's potassium. And as we all know from taking chemistry in college and learning more about this in medical school, if it starts with an S, that means sodium, because as we know, the chemical symbol for sodium is S. No, that's obviously not the case. Somehow, for some reason, the sodium channel gene was called SCN5A. So that is associated with long QT syndrome type 3. If it's a gain of function mutation in the SCN5A gene. If it's a loss of function mutation in the SCN5A gene, you wind up with Brugada syndrome. So all forms of long QT syndrome are autosomal dominantly inherited, passed along usually from affected parent to affected child. And there is one exception to that, Jarvell-Lang-Nielsen syndrome, which is a condition that's more severe than these other types of long QT syndrome and have other non-cardiac effects as part of the phenotype, including sensorineural hearing loss, which usually begins early in life. And people with Jarvell-Lang-Nielsen syndrome have pathogenic variants in both of their copies of the KCNQ1 gene. So both of their parents frequently will have features of long QT syndrome type 1. So all forms of long QT syndrome are associated with similar symptoms. So on the basis of their clinical findings, you can't distinguish one form of long QT syndrome from another. All of these individuals will have features such as dizziness, syncope, palpitations, episodes that look like seizures but are actually related to cardiac rhythm disorders, and sudden death. And sometimes the sudden death is the first symptom that they have. So often we'll find families where there are individuals who have had no previous history of syncope or dizziness or palpitations who will just die. And if individuals die before the age of 1, they're described as having SIDS, sudden infant death syndrome. If death occurs after 1, they're said to have sudden unexpected death syndrome. So let's look at those 2 conditions for just a minute. Again, SIDS occurs in kids under 12 months of age. About 20% of cases of SIDS are associated with pathogenic variants in channel genes. Again, this is important because if you find a baby who's died of SIDS who has a pathogenic variant in one of the potassium channel genes, say, that child, one of that child's parents is going to also be carrying that pathogenic variant and therefore at risk for sudden death. It's important to note that the percentage of cases associated with variants, pathogenic variants in channel genes has increased with our ability to test more and more individuals and do more and more testing. And also an increasing number of genes have been identified that are associated with channelopathies in these individuals. but again, still at this point, even though we know that some percentage of kids who die of SIDS have a channelopathy, the majority of cases are still unexplained. You might argue that, well, we do newborn screening for other conditions. Why not do an EKG on all newborns to see if they have a prolonged QT interval? That's been tried, and it hasn't been very effective. The effectiveness of looking at QT intervals as a predictor of who's going to wind up dying of SIDS is not very helpful. And it also raises the question: are babies who are stillborn or are late fetal demises associated with channelopathies? And that really hasn't been looked into in very good ways yet, but that needs to be done. As opposed to SIDS occur in people over 12 months of age. If you look at people 35 years of age or younger who have died suddenly without an explanation, about 40% will have identifiable genetic etiologies. Some of those will have long QT syndrome, some will have Brugada syndrome, and there are smaller amounts of other conditions that are associated with sudden unexpected death. In these cases, the EKG is more helpful, as was the case in predicting the cause of death in Miss V, or probably the cause of death in Miss V. So, but who cares? What difference does it make which gene is involved? If you have long QT syndrome, you have long QT syndrome. Does it make any difference whether you have a potassium channel mutation or a sodium channel mutation? Well, it turns out that it does, because specific variants that lead to long QT syndrome have different environmental triggers that cause the arrhythmia and different treatments. So identifying the specific pathogenic variant permits us to provide really personalized care and treatment for that individual. And that is really the basis of precision medical care. So as an example, here's a graph that shows the cause of gene-specific event triggers in people who have long QT syndrome type 1 on the left, long QT syndrome type 2 in the middle, and long QT syndrome type 3 on the right. And you can see that in long QT syndrome type 1, 62% of cardiac events were triggered by exercise. So these are people who are playing basketball, running up and down the court, and drop to the ground, either dead or requiring resuscitation because they've had a cardiac arrest. This is not the case in people who have long QT syndrome type 2, where, as you can see, only about 13% have an event related to exercising, whereas a larger group have events related to emotion. So they get bad news and they can have an arrhythmia, and they can have events riding on a roller coaster, or they can have an event when they hear a loud noise, like the alarm clock going off in the morning, or the phone ringing very loudly. And that differs from type 3, long QT syndrome type 3, where neither exercise nor emotion play a major role. The most common environmental factor leading to an episode is sleep. So there's not much we can really do for those individuals, but we can direct therapy to the genotype. And so for long QT syndrome type 1, we can give beta blockers, which slows down the heart rate. The problem being that when you exercise, you wind up raising your heart rate, and that can predispose you to having an arrhythmia. Also, we advise those individuals to avoid competitive sport. Don't play basketball, don't swim, certainly not alone, which is a common way that people with long QT syndrome type 1 die. That's different from long QT syndrome type 2. We also use beta blockers in people with type 2, but will advise them to not use alarm clocks that have loud ringers and remove the auditory ring from phones. So we don't tell them not to exercise. So that's another issue. In type 3, they may there's really not any you have to sleep, so there's not much you can really do to tell them not to do when they're to prevent a cardiac event from occurring. Pacemakers may help with them. And there's some question about whether low doses of mexiletine versus a beta blocker will help. In all cases, if medical management doesn't work so well, an internal cardiac defibrillator may need to be implanted. Also, there are drugs that in all cases that can prolong the QT interval and make more likely that the person will have a cardiac event. So we advise families to check before taking any medication or any kind of substances. There's a website called crediblemeds.org. There's also an app for iPhones, and you can check. This is a listing of all the drugs that people with long QT syndrome should avoid. And we advise people to check on crediblemeds.org before they take any new meds. Back to Miss V. So as I've already said, Miss V had 2 sons, age 6 and 4. We know that because she carried a variant, she was heterozygous for a variant in KCNQ1, that each of her sons had a 50% chance of having inherited that. And if they had inherited it, they also were at risk of sudden death, increased risk of sudden death. So it's a tragedy to have one person die and wind up having no explanation for it. But if we miss the opportunity to identify a cause and to counsel the rest of the family about their risk, and another person dies, that's a much worse tragedy. So we contacted the father of her children, and he agreed to bring the boys for evaluation. And at initial evaluation, so just to let you know what we do with families when we see them, we do a pre-visit phone call usually. First, we review the medical records to see what we're actually looking at or dealing with. A genetic counselor will call the family and will construct a 3-generation pedigree looking for similar and dissimilar problems in other family members. And she will also do an assessment of the family's psychological state. We're dealing with families that have lost a loved one in the recent past. A lot of times these families are in mourning when they come to see us. So they're mourning the loss of the loved one. And on top of that, they're learning, probably for the first time, that they themselves may also be at risk for sudden death. So it is an emotionally very difficult time for a lot of families. And again, people with long QT syndrome type 2 may suffer as a result of having this emotional upheaval. On the day of the visit, a nurse takes their vital signs and performs an EKG. We contract with the family, discussing with them why they're there, if they understand why they're there, what they would like to get out of the visit, what we would like them to get out of the visit. And, so we come up with a plan before we've actually seen them of kind of where this is going to go. We take a history and pedigree if the pedigree hasn't been done beforehand. There's a clinical evaluation of all the individuals, and this is a whole family usually that we see. We may have parents, we may have children, we may have uncles and aunts who come, basically any first degree relative of an individual who has died because of or related to a cardiac rhythm disorder. So we do a social work assessment, especially looking for signs of depression and problems with bereavement. And we review the lab data. A lot of the patients who we see will have an EKG before they come to see us. We'll also do that. We can do echocardiograms at the time of clinic. They might have stress tests done. They might have Holter monitors and event recorders that have already been done. Some have tilt table tests before they come to see us. So we review whatever's available. We then have a discussion of between the cardiologists, the geneticists, the genetic counselors about what the best course of action might be in this particular family. Sometimes it's very easy because we're just doing familial variant testing. Sometimes we have to reach farther and try to figure out what tests need to be done. We then talk with the family and go over all of this and come up with a final plan of what we're going to do. So that's basically our background. Again, there's special cases when the families are coming to us after the recent death of a loved one. These families may be in mourning, and this needs to be acknowledged, and they need they may need help for this. And we can refer them for ongoing psychological counseling. So back to Miss V. And again, we evaluated Miss V's sons, and some of this is covered in the essay that I think you've been given called The Kid Had to Pee. Both boys had normal physical exams. Both had essentially normal EKGs, although Chris Walsh felt that the QT interval may have been slightly long or upper limits of normal in both boys. We offered, and the family and the father agreed to family-specific genetic testing. The testing revealed that both boys had inherited the deleterious variant from their mother, and so both were at risk for sudden death because of long QT syndrome type 1. It's important to point out that in Miss V's case, she had this underlying cardiac rhythm disorder, which under normal circumstances seemed to be in check, didn't cause major problems. But when she used certain medications, probably cocaine, this probably adding to her underlying long QT syndrome led to the fatal event that occurred. So it was important to counsel the father about the importance of having the kids stay away from drugs. And management focused on preventing sudden death in Miss V's sons. Both were started on beta blockers. Both come back every year for follow-up visits. And again, they were instructed about the use of crediblemeds.org. So here, just to review this, these are my rules for genetic testing. So first, the initial DNA testing needs to be done on the proband. The proband is the person with the disease. The proband is not necessarily the consultant, that is the person who's coming to see you. So we'll frequently see families that have a history of somebody who died suddenly but has not had genetic testing and we have no information about what caused that person to die. And they want to be tested for the possibility of an inherited cardiac disorder that may put them at risk for sudden death. But since the individual who died suddenly, the proband, did not have testing the consultant is not usually helpful. If that test is positive, that is, if we find a pathogenic variant in that person, then it's probably helpful. But in the vast majority of cases, we'll find a negative testing. And in that case, we don't know if the testing is significant in that because we don't know what the proband had, whether the proband had a pathogenic variant that caused the problem. So a negative result may mean that you're negative, that you don't have this, or it may mean that this isn't an informative family that we really can't tell. So you really have to start with the proband. However, when DNA from the proband is not available, we can proceed with testing the consultant with caution, understanding that a positive result may be significant, but a negative result may not be significant. And finally, DNA testing spreads from the proband to first degree relatives. So the proband's children, his or her parents, his or her siblings. And then on the basis of the testing of the first degree relatives, second degree relatives, the children of a sibling who tests positive for the pathogenic variant can be tested. But of course, if the first degree relative, the sibling, is negative, there's no need to test anybody else in that line of the family. So those are just my rules. So we've talked about Miss V. We'll move on to a second patient who was not actually sent to us from the medical examiner's office, but illustrates some really important points. And this is Mr. P. Mr. P was a 52-year-old man who was self-referred. He provided this history. 4 months before his visit to us, he'd been out on his usual weekend 50-mile bicycle ride. He rides 50 miles every weekend, or he did up until this point. He was a very fit non-smoker. He'd been totally asymptomatic. He hadn't had any symptoms related to heart problems at all. It was August, so the day was hot and humid, and he'd forgotten to bring his water bottle. And he rode on for about 5 miles and then stopped for breakfast at a local deli where he had a bacon, egg, and cheese sandwich on a roll with coffee. He was very fit, but his nutrition wasn't so good. After his breakfast in the deli's parking lot, he got back on his bike and began riding again. He said that he developed the worst indigestion he'd ever had, which resolved within a couple of minutes. But then after about 15 minutes of riding, he fell to the ground, essentially dead. The fall was witnessed by a passerby who happened to be an ED nurse. She assessed that he was asystolic and began CPR almost immediately, within less than a minute. An ambulance was called. He was transported to a local hospital, and he was resuscitated. And in the local hospital, he was found to have normal cardiac enzymes and a normal EKG. So it wasn't clear what had happened to him, what had caused him to have this cardiac arrest. He was transported to a tertiary care hospital where a cardiac cath was performed, which disclosed 85% blockage in 2 coronary arteries. As a result of that, 2 stents were placed, but also because they couldn't ascertain what actually had gone wrong, an internal cardiac defibrillator was also placed. And his discharge diagnosis from that hospital was silent MI. But he had doubts about this diagnosis from the beginning. His family history was concerning. His mother had died at 57, a few years older than him, of a heart attack while she had been exercising. An autopsy wasn't done. She had had no history of heart disease prior to this. So he doubted that this was actually a straightforward myocardial infarction. He also had a brother who was told that he had an arrhythmia, but information about the brother is not available because Mr. P and his brother had a big fight around the time of his mother's death, and they haven't spoken to each other in years. Also, Mr. P has a son who's now 16 years old, and he has a history of fainting with blood draws. The first episode occurred when he was 2 weeks old. I spoke with the pediatrician about this because I couldn't really believe it. And the pediatrician told me that he had a newborn screen that showed possible hypothyroidism. They wanted another sample. The pediatrician drew the blood himself, and he said that as soon as the blood, he stuck the needle in his vein, as soon as blood appeared in the tubing of the butterfly needle, the kid passed out. His eyes closed. He stopped breathing. He was really comatose. The guy was going to start CPR, and he took a breath and started up again. So this was really very troubling at 2 weeks of age. Mr. P reports to us that, and by the way, the son continued to have episodes of syncope every time his blood's drawn. Mr. P reported that since the placement of the defibrillator, he's had no symptoms and signs, and he's had no shocks. So we agreed with his concern, and based on the history and the family history, we sent an arrhythmia panel to a commercial lab, and sure enough, he was found to have a variant of unknowns of uncertain significance, a VUS, in SCN5A, the sodium channel gene that's associated with long QT syndrome when it's a gain of function mutation, and Brugada syndrome when it's a loss of function mutation. The lab noted in their report that this variant had been reported in 2 families with long QT syndrome, but that it's been seen in about 0.5% of the quote unquote healthy population. This is unusual because usually if a variant is pathogenic, you will not see it in a high percentage of the general population, and this percentage is much higher than we would expect for a pathogenic variant. So how do we determine if a VUS, a variant of uncertain significance, is disease-causing or benign? So we review the literature, which has already been done. We look at the in silico analysis, in other words, looking at the protein that results from the amino acid substitution that results from the variant, and see if the variant seems to work or not. And there are different factors that we look at for that. In this case, the in silico analysis was mixed. It really didn't point to either it being pathogenic or not pathogenic. We could do family testing to see if the variant accompanies a phenotype that's associated with this disorder. But in this family, we couldn't do it because there were no individuals available. If the mother had survived her episode of sudden death, we probably would have been able to test her to see if she had the same variant of uncertain significance. But we really didn't have anybody, and also his brother, but he wasn't available for testing. So this was not available. So we turn to molecular phenotyping in this case. That is generating the channel which results from the protein formed by the variant SCN5A gene, construct the channel and see if it works in vitro. And Dr. McDonald's lab is set up to do this. They generated the protein from Mr. P's variant, and they analyzed it under standard conditions and altering the environment in which it was being expressed to see how it stood up. And what they found was that under standard conditions, the sodium channel worked normally. But when the pH was lowered to 7.1, the protein denatured and the sodium channel collapsed and stopped working. So basically, what we thought happened with Mr. P was that it was the perfect storm. The VUS in SCN5A predisposed him to develop a lethal arrhythmia under acidotic conditions. And he had managed to achieve the acidotic conditions by a combination of his underlying partial occlusion of his coronary arteries, decreasing the amount of blood that was going to his heart muscle, the vigorous exercise that he was doing, shunting blood to his muscles, the heavy breakfast while exercising, which caused a lot of his circulation to wind up in a splanchnic circulation, and his relative dehydration. All of these came together to cause his the localized acidosis in his heart and led to the fatal arrhythmia. So really interesting, but once again, who cares? So what? He's got an ICD in place. His management is not affected. The issue is his 16-year-old son. His 16-year-old son has a 50% chance of having inherited this variant. And although he's in good health, he does have this history of syncope associated with blood draws. Um, these episodes, investigating this further, last for less than 1 minute, are preceded by a prodrome. So he gets pale, he gets diaphoretic, and he gets lightheaded as the blood is coming out. And he was worked up for this at another hospital. He had a normal echo, a normal EKG, a normal EEG. Um, they didn't do any stress tests, so they didn't get his heart in a position where the local pH may have been acidotic. Um, they diagnosed vasovagal syncope, and again, no stress test was done. So, what we wanted to do is offer testing to the son to see if he had the same variant, that if he had inherited the variant from his father. So, and we counseled the parents about this. Mr. P and his wife, they chose not to inform their son of the results of the father's test. Their thinking was, he's been through so much already with his father having had this episode, and his whole lifestyle changing as a result of it. Also, the son, whose name is Ricky, was applying to college at this point, and so he had a lot on his mind. They felt he didn't need to have added to that the possibility that he might die suddenly. But they agreed to permit him to have yearly follow-up visits with Dr. Walsh to assess his cardiac rhythm and review his history. But when he came for these visits, they would not allow us to tell him what we were looking for, which was uncomfortable. And this raises all sorts of ethical issues, as a lot of these cases do. So I'm just a few of these I'm going to focus on. Should parents have the right to withhold information, genetic information from their child? Really, who owns the genetic information? And who else should have access to it? Should Mr. P's employer know that he has this? They pay for the genetic test. Should they know the results? Should his insurance company know about this? Again, this is way beyond the scope of this talk, but in focusing on Ricky and his parents, should a 16-year-old be able to decide for him or herself about whether to have a test that impacts his or her life? And if you say yes, if a 16-year-old should be able to make this decision, should children be consulted? Should a 12-year-old be able to decide? If so, should an 8-year-old? There comes a point where probably the child needs to be of a certain age to understand what the implications are and make the decision. So Ricky applied to college, went to Cornell. When he left home, he wasn't tested, and I really freaked out. And the reason for that was because of the case involving a woman named Lauren Spearer. So Lauren Spearer was a woman who, in June of 2011, she was a junior at Indiana University, and she disappeared. It was finals week. She had completed her finals. She was out partying with her friends, and she was seen in a bar. She was seen going to a friend's house, and then she's never been seen again. She had been diagnosed in childhood with long QT syndrome type 1, and she was on a beta blocker. Presumably, she had been counseled about what she should and should not do to protect herself. I'm afraid that what happened was that she either electively or not electively got into some drugs that as part of this partying, and it caused her to have a fatal arrhythmia, and her friends panicked and hid her body somewhere, and she's never been found. And it's now been 11 years or 12 years, and her parents continue to grieve, but no information about what happened to her has been discovered. Back to the P family, though, for years after Mr. P's diagnosis, The family declined to even inform their son of his risk. But in 2022, last year, he became engaged, and his fiancee heard this story, and she convinced him to seek some counseling. This was done not at our center because he had moved away, but he met with a genetic counselor and decided to proceed with testing for the familial variant. So finally, we'll know if Ricky is carrying his father's variant and therefore at risk for sudden death or not. So he was tested, and the testing revealed that he had not inherited the variant in SCN5A from his father. He was greatly relieved. His wedding occurred sometime earlier this year, and the family lives happily ever after. So, in summary, we've discussed how molecular panel testing performed on decedents can inform and impact the lives of their survivors. We've reviewed how our multidisciplinary cardiogenetic clinic works, and how we deliver precision medical care to families that have lost a loved one. We've described how interactions between a medical genetics lab run by a medical examiner's office can successfully interact with a collaborating clinic to provide care to families of decedents who died suddenly. And so thank you, and thank you for listening.